Our second speaker of the day is Dr. Jatin Shah. Dr. Shah is our chief of head and neck cancer surgery here. The head and neck surgery just celebrated 100 years, Chief? 100 years of thyroid cancer. He was 6 at that time, so he's amazingly well preserved at 106 years old now. So he's been chief of this place forever. When I came here in 1999, Dr. Shah said, Michael, thyroid cancer is not all that complicated. If you understand the natural history of this disease, if you understand how this usually works, you'll be able to do a good job with thyroid cancer. So here I am 15 years later, still trying to figure that out. Seems pretty simple to him, and he'll tell us about it this morning. Jatin.
Thank you, Dr. Chattel. Good morning, everybody. And again, good morning, and thank you for coming down on a beautiful weekend Sunday morning. Rather than taking a walk in the park or on the streets going shopping, being in the auditorium, listening about thyroid cancer is not quite an exciting spring activity. All right, so I think, Dr. Tuttle has very beautifully laid down the ground as to what thyroid gland is, what thyroid cancer is, and we will now explore further into it to have you understand what the disease is all about, why we do what we do, and what would be the impact on you as patients and from the point of view of us as surgeons as to, and physicians as to what the outcomes we anticipate. So I think you already heard this from Dr. Tuttle at the beginning, that thyroid gland is an endocrine gland compared to other exocrine glands like the salivary glands, pancreas, which secrete their secretions into the alimentary tract, into the stomach, into the intestines. While thyroid gland produces its own secretion, a hormone called thyrotropin, and instead of putting it into the intestinal tract, it puts it directly into the blood. And that is the reason why it is called an endocrine gland. And the purpose of the hormone it produces is to maintain metabolism of your system. Simply put, it's like oil in the machinery. For every part of your machine that works, you need oiling to have the machine work well. And similarly, you need thyrotropin for your heart to pump, for your lungs to breathe, for your liver to function, for your brain to function, and so on and so forth. You already know where the thyroid gland is, in the neck. But what I will share with you, if we had a pointer here, if that's all right, I'll show you with this. Near the thyroid gland, there are other important vital structures. And when you're talking about surgery, you're not just talking about the thyroid gland, you're talking about the structures adjacent to it, which are of crucial and vital importance. So if we, for example, flip this thyroid gland backwards, then you find on the back side of the thyroid gland are these little 4 yellow dots called the parathyroid glands, and they control calcium in your body. So you will, those of you who have been patients may have heard your surgeon telling you about the parathyroid glands and the potential injury to it or risk to it, because we may have to remove them sometime, and its impact on your calcium levels. And the reason for that is they are directly adherent to, stuck to the back surface of the thyroid gland, and we as surgeons have to peel them off to protect them to maintain your calcium levels normal. So we turn that anatomy a little bit at a 45-degree angle, and here you see your voice box, the larynx, commonly visibly the Adam's apple in the neck, and that continues further down as your windpipe, the trachea, and behind that is your esophagus, where you swallow food going down into the stomach. And all of this is tightly packed within about a 2 square inch area in the lower part of the neck. So let's look as to what are the areas at stake. So here is your thyroid gland, that's your parathyroid glands. Right next to that is your nerve to the vocal cord, between your windpipe and your esophagus, and right behind the thyroid. So that could be at risk either of invasion by the cancer or a surgeon either injuring it or having to remove it. Similarly, if a thyroid cancer grows into the further backwards, it can involve your voice box or your windpipe or your esophagus, or even more advanced cancers can go on to involve your carotid artery that takes blood to the brain. So we are dealing with a very complex, tightly packed anatomic area with several vital structures which we should be concerned about. Now, as Dr. Tuttle said, the thyroid gland can get bigger for a variety of reasons. And physiologically, the thyroid gland grows a little bit in women at the two important periods in their life, during puberty, because the young girl is growing and needs a larger hormonal production, and the entire gland diffusely gets a bit bigger. Similarly, at menarche, thyroid nodules appear, and you might find that a goiter or an enlarged thyroid gland can become apparent, and it's quite common, as you were told, in the United States. It's more common in women than in men, nearly 8 times more common than men. Now, if we were to do ultrasound on, and God forbid, please don't go and ask your doctor to do an ultrasound. You might wind up buying yourself an unnecessary operation. But these are numbers that exist. If we were to do ultrasound on everybody walking on the street, about a third of women will have thyroid nodules. Remember, all of this is not cancer. Less than 10% of those are going to be malignant. And if they are essentially curable malignancies. So no alarm. And thyroid nodule is a fact of life, is a part of your life, and it should not necessarily make you nervous. So how often are these nodules or the goiters malignant? The incidence of thyroid cancer in goiter is variable in various parts of the world. It's highest in the Philippines, and there is a variety of reasons, because there are many areas in the Philippines which are iodine deficient, leading to development of goiters. And in the published data from Philippines, when women or men undergo surgery for benign goiters in the Philippines, about a third of them wind up having cancer within those goiters. That's a huge and perhaps the highest number in the world. In the United States, the incidence of finding cancer in a goiter enlarged thyroid gland is less than 10%. If the entire gland is diffusely enlarged, the risk is even lower. It may sound paradoxical, in contrast to a single nodule. So one would think, why would I expect a cancer in a small single nodule versus the whole gland being big? But that's a fact, that when you have an enlarged thyroid gland which is diffusely enlarged, the risk of that being malignant is very low. In contrast, a single nodule has a higher risk of showing cancer in that. Keep in mind, either way, if you find the enlarged thyroid gland, that's a reason to get investigated further. Now, this was the beautiful slide that Dr. Tuttle showed of the iceberg. Microscopic or minute thyroid cancer may be present in as many as 10% of patients in the United States, people in the United States. That incidence of occult or microscopic cancer is highest in Finland, 36%. That means 1 out of 3 Finns have thyroid cancer in their thyroid gland. But that doesn't mean Finns have a higher mortality from thyroid cancer. It's just the incidence. And this was told to you by Dr. Tuttle, that 10% of people in the United States are found to have occult cancer when at autopsy, when people die of a stroke or a heart attack or a car accident, autopsy is done. You take out thyroid glands after death, 1 out of 10 will have thyroid cancer, which never surfaced or came to life during the patient's life. So that means that person lived with their thyroid cancer throughout the life without it becoming clinically manifest or clinically significant. And to give you an example, we are a country of 300 million people. 10% of US population is having occult thyroid cancer. So there are somewhere between 30 and 40 million people in the United States walking around with thyroid cancer. Should we alarm and tell the media that go get your ultrasound? Because then the sonographers will have a bonanza. 38 million ultrasounds to be done. The reason for this is that I would say more than 90% of these cancers are essentially benign cancers, a paradoxical term, meaning that these are cancers that will never surface, they will never come to life, they will never become a threat to your life or become clinically significant enough to require treatment. Just the fact that there is a minute or a microscopic cancer in the thyroid gland is not a cause for concern. Now, why does thyroid cancer occur? Do we know? I mean, I get the question of, doctor, why me? When I see the patient in the office. Well, we don't know the exact cause of thyroid cancer in all patients. There is increased risk from radiation exposure, we know that, and I will share some data on that. And particularly, if radiation exposure occurred during your childhood, the risk is much higher. We also know that if you come from iodine deficient area, they don't exist in the United States, but in those parts of the world, iodine deficiency is still present. The risk of goiters is higher, and the risk of thyroid cancer is higher, as I told you about Philippines. Michigan was a state prior to 1960 where around the lake, there were many areas which were iodine deficient, and the incidence of thyroid cancer in Michigan, Illinois, Indiana was much higher prior to 1960 than what we see today. Is there a strong familial implication? I probably don't think so, but if your grandma had papillary cancer, your aunt had papillary cancer, and you have a thyroid nodule, I would be a little bit more cautious in not neglecting that. You want to check that out. So if you have a strong family history of papillary carcinoma, be a little bit more cautious to investigate the thyroid nodules. And as Dr. Fagan will talk to you later in the afternoon, there are numerous genetic mutations which may be the cause for genesis of thyroid carcinoma during life. Now, this is the story I was going to talk to you about, radiation exposure. Everybody heard about Chernobyl, the radiation fallout following the accident in 1986. And if you look at the development of thyroid cancer in people exposed following the radiation fallout in Belarus, for example, the incidence of thyroid cancer plummeted. In children, shown in red, 1986 was the accident. Within 2 years, it went up like a rocket. And so much so that these children, every child in the school and the kindergarten had to be screened. It reached peak at about 8 years following the radiation fallout, and then it started dropping down, bringing it to normal incidence by year 2002. So children were the first to be affected. Adolescents, shown in blue, and adults had a larger latent period, but they also showed a steep rise in the development of thyroid cancer. And in adults, it was still climbing just 10 years ago. It probably has flattened out now. This observation was previously noted following the atom bomb attack in Hiroshima and Nagasaki, where also the incidence of thyroid cancer in the population went up. And I'm sure in the next few years, we are going to hear again from Japan, from the Fukushima accident, that thyroid cancer is rising. So I think that is a known causative factor. There is also a term which you might have heard some doctors mumbling in their discussions. Oh, she has an incidentalloma. What is an incidentalloma? It's not a medical term, by the way. It's a term derived by colloquial language. Incidental, and oma means a tumor. Incidentally found tumor is an incidentalloma. So many small thyroid cancer are diagnosed during a routine physical examination. You go to your GP for your annual exam, he's running his hands around, oh, what's this? And that's an incidentalloma. You have no symptoms, you have no signs, but it is incidentally found. More often we see now that these are seen either on a sonogram done to study your carotid arteries, or a CT scan done for your sinusitis, or an MRI done following a car accident for whiplash injury, or a PET scan done for some other reason, and you find a little dot of the thyroid gland. So these incidentally found or diagnosed tumors we call incidentalomas. And they may account for at least a large proportion of the steep rise in the incidence of thyroid cancer. You saw this graph from Dr. Tuttle before, but he showed you a very boring black and white slide. So I made it colored, Mike. I'll share this with you if you want. So as you heard, this year in the United States, we will see over 62,000 newly diagnosed thyroid cancers. Just 25 years ago, that was only 8,000. So we are seeing 8 times more thyroid cancers today than we did some 20, 25 years ago. Most of these rises in women. Also, although there is a modest rise in men also. But important to see in this graph is not attention on this, which is alarming, but the attention on this green line, which is the mortality. That has remained the same. So what does it tell you? That the majority of the newly diagnosed thyroid cancers we diagnose today are curable cancers. They are not the cause of mortality. The flip side of the coin is we as physicians need to spend more time in changing this line. That's where research and new therapies come into picture, where the more aggressive or the more serious thyroid cancers need to be treated so that we can reduce the mortality from thyroid carcinoma. You saw this 2015 estimates, over 62,000 patients, but the deaths from thyroid cancer are stable at around 2,000. At our own institution, here at Memorial Hospital, just even go back 10 years, 15 years, and we are seeing less than 200 thyroid cancers a year. Last year, we saw over 1,000 thyroid cancers. So in our own institution, the reflection of the rising incidence is manifested here. So the bad news is that the thyroid cancer is rising, and should we be alarmed about it? Of course, we should be conscious about it, but not necessarily alarmed about it, because the good news is it has not caused or increased the mortality from thyroid cancer. So let's go on the bad news, good news scenario. The bad news is the steep rise in the incidence of thyroid cancer. It's been called in the media to be the fastest rising cancer in the United States. Statistically true. It generally affects young adults, mostly in women, and has truly become a major healthcare problem. Give you a simple example. On the head and neck surgery service, up until year 2000, thyroid operations composed of only 10% of all operations we did. Today, 50% of all operations we do are on thyroid gland. So it has become a major healthcare problem. But the good news is, majority of these are asymptomatic and incidentally found small cancers, less than 2 centimeters in diameter. The treatment is simple and safe, and nearly all cancers are curable in the young patient. The diagnosis is made relatively easy. We have to be slightly more suspect when a thyroid nodule appears at the extremes of age, in the very young or the very old. As I said earlier, single solid nodule has a higher risk of finding malignancy. The nodule that is growing, your GP may have said, this is a 5 millimeter nodule, no worry, we'll get an ultrasound next year. You do it every year, and now that 5 millimeter nodule is 8 millimeter nodule. The following year it's 12 millimeters. It's time to pay attention to that. Certain physical characteristics of the nodule will increase the risk of finding cancer. And there are other symptoms and physical findings. You have a thyroid nodule, and suddenly you wake up one morning and you start talking like this. Doctor, I was fine, but I lost my voice. Alarm. Go to the doctor immediately. So if you have any symptoms, that either develop suddenly or even gradually progressing. I'm feeling a bit pressure in my neck, or I'm having trouble swallowing solid food. It takes a little time. Go check out. The diagnosis is confirmed usually by a simple test, fine needle aspiration biopsy. Those of you who have been former patients know that that's the first thing you encounter as an invasive or a interventional procedure. And it may be done if it's a large nodule without ultrasound, simply stick the needle in. If it's a small nodule, you may need ultrasound to locate that and get the biopsy from that nodule. Once the diagnosis of thyroid cancer is made, at your end, the wheels of anxiety, apprehension, fear, future, and reality starts turning. Joan is a perfect example. Why did she set up the Light of Life Foundation? I remember when Joan had her surgery. I think I was the young attending at that time, had just joined the service some 2.5 decades ago. The level of anxiety in her and the fear in her is the reason why all of you are here today. So this is the reaction you get. Why me? Oh my God, have mercy. And this is true, because nobody likes the word cancer. So when I see patients who walk in with the history of having biopsy-proven thyroid cancer, my first statement is, cool down, you are not going to die from your cancer. And then the discussion begins. So these are the questions you would pose to me, and I summarize them because I get these questions asked every week. Why did I get this cancer? My answer is, I don't know. Am I going to die? My answer is, most likely not. But first I tell them yes. So then their face drops. But then I tell them, I am also going to die. Then they lighten up. Because everybody's going to die. There is nobody who's going to live forever. But then I expand upon that and tell them, yes, you will die, but very unlikely that you will die from your thyroid cancer. Then the friendly endocrinologist told me that I need a total thyroidectomy and radioactive iodine treatment. Please get my thyroid out so I can go and get radioactive iodine. So I said, please quiet down. They've already seen a couple of surgeons before they came to me, and some young hotshot surgeon told the patient, you know your thyroid cancer can be in the lymph nodes, and you should not only have your thyroid out, but the lymph nodes also out. Good for his business, but you may not need it. They, meaning your friends, your neighbors, your well-wishers, told me that I will get fat after surgery, that I may talk like Lauren Hutton, that I may have to take calcium every day for the rest of my life, and can my children get cancer? So all of these questions are natural reaction to the diagnosis of cancer. How instead of me answering all these questions, I tell them that let's understand what your disease is all about. And if you understand this, then you are in sync with us, the physicians, in tailoring your treatment to your problem and to your needs and for your benefit. It's a little bit sounds complicated, but I'll make it simple for you. We know what the thyroid gland looks like. It's like a butterfly. And you saw, Dr. Tuttle showed you that slide about the follicular cells around the colloid. So these follicular cells normally reside in your thyroid gland and normally function to produce the hormone which controls your metabolism. Something happens, and I use the word something because we don't know what is that stimulus. Maybe radiation exposure, and in many patients there is no apparent cause, but something goes awry, and these normal follicular cells start turning into becoming malignant, and they may become either a papillary cancer or a follicular cancer. Over 85% of the patients who present to us will present with, at this stage of the disease, which is usually a low-grade cancer, and carrying a good prognosis. A distinct minority, less than 10%, will go on to have this cancer progress further along the cancer progression model and go on to become somewhat more aggressive cancers, called the tall cell cancer, insular carcinoma, or may go on even to become poorly differentiated, meaning more aggressive cancers. The prognosis in them is not so good. And these are the patients who need aggressive surgery, aggressive radiation, or even aggressive chemotherapy. But fortunately, they are a minority, about 10-12%. And we know that even at the beginning, at the outset, that 1 centimeter papillary cancer is not going to turn this route. It's the person who walks in with a 5-6 centimeter large cancer that we are worried about this. And very occasionally, this can go on to become even a more aggressive, nearly fatal cancer. Fortunately, less than 2%. And this is our big problem. This is where we need to spend time, money, energy, and resources to find cure, because these are the cause of mortality in thyroid cancer. These folks don't die. These are the ones who have a risk of death. And that's where we need to spend time and energy. So if I summarize that biological phenomenon, majority of well-differentiated or papillary carcinomas, which are low grade, are nearly all curable. The very aggressive anaplastic carcinomas are rarely curable. They're very aggressive. Here we need to do investigative new modalities of treatment and need time and money in research. And these are the patients in the middle, which are the poorly differentiated, somewhat aggressive cancers, where we need aggressive treatment, aggressive adjuvant treatment, radiation, radioactive iodine, and even chemotherapy, and attempt to cure these patients. And even a majority of these are curable, but these may account for being called serious thyroid cancers. Now, don't worry about all of this. This is a very confusing slide. I'll try to make it simple. There is data existing from major institutions in the country and abroad, and I've showed here from the Mayo Clinic, Lehi Clinic, Karolinska Institute in Sweden, and our own data from Memorial Hospital, identifying what matters in thyroid cancer as it relates to your life, which we call prognostic factors. You will notice in none of these, we are talking about the operation, the radioactive iodine, the radiation, or whatever. So what we do is important, but is not the calling card. The calling card is the biology of your disease. So if I put all of these prognostic factors into a simple diagram, this is what is easy to convey. As you get older, the risk of that being a serious cancer becomes a reality. So under the microscope, a papillary cancer of a 30-year-old will look the same like papillary of a cancer of a 70-year-old. So if you give the two slides to the pathologist, he can't tell me who is 30 and who is 70. But the 70-year-old has a higher risk of dying from that cancer than the 30-year-old. So age is a prognostic factor. Like everything else in life, women rule. We may even have a president who is a woman. So women carry a better prognosis than men. Size matters, like everything else in life. Tiny cancer is easily curable. Even little bigger cancer, as long as it remains confined within the thyroid gland, it's easily curable by simple surgery. The problem arises when the cancer extends outside the thyroid gland, or more importantly, it involves the adjacent organs, the voice box, the windpipe, the esophagus, your nerve, and so on and so forth. These are serious cancers. These need bigger operations and bigger additional treatment. It also matters about the aggressiveness of the cancer. Remember, I showed you on that tumor progression model, those with tall cell cancer, poorly differentiated carcinoma. And when the disease is widespread already at the outset, the prognosis is not that good. So if you understand this, then your level of apprehension will be much less, because majority of you are going to be residing in this area. And that's why you are here. The ones who had problems here couldn't make it here because they are no longer here. So how do we translate this into our treatment philosophy? And that's what Dr. Tuttle told you about risk group stratification. So we classify our patients into 4 groups of patients as they walk through the door. Low-risk group patients are younger patients, younger than 45, generally females, with small tumors, less than 4 centimeters in diameter, which are contained within the thyroid gland as seen on your ultrasound. They are well-differentiated cancers, and they have no evidence of distant spread. These are considered low-risk tumors where we have essentially a guarantee that you can be cured, and therefore we don't need to be over-aggressive. The flip side of the coin is older patients, generally men with large tumors, which have extended beyond the thyroid gland, and those who may have distant disease are high-risk patients. And there we need aggressive treatment. And then you have younger patients with bad cancers or older patients with good cancers. They fall into the intermediate risk group category. If you look at outcomes at 10 years after treatment, under age of 30, nobody died of thyroid cancer, 100% survivorship in patients under the age of 30. Under the age of 40, at 10 years, 10-year disease-specific survival, 100%. So we start seeing the impact of the disease on your longevity as you get older. At 50, we are talking about 3% risk of death. At 60, about 5-6% risk of death. At 70, 10% risk of death. And over 70, as high as 20 to 30% risk of death. So it is a phenomenon which needs attention for the older folks. Now this is a curable cancer. This young girl comes with a huge apprehension, and my first reaction to her is, relax, you are going to be fine. Yes, you will have a tiny scar. Her concern is, am I going to have a scar in my neck first? So we have to address that. And the second cancer is, can I have children? And third question is, am I going to live long enough? And the answer is yes, yes, and yes. So, but there are others who come with large tumors, or even larger. Is an older woman in her 70s with a huge cancer. This is serious business. Or this, bilateral a tumor in an older gentleman. These are serious cancers. Not this thing. This is curable, fixable, almost guaranteed, and with essentially no impact on longevity or life quality. But these are serious problems. Sometimes you become with enlarged lymph glands in the neck. And here also your age matters. Younger patients will do well. Surgery is the definitive treatment for thyroid carcinoma. And in many patients, surgery alone is curative. We don't need anything else. All other treatments that Dr. Tuttle mentioned to you about, radioactive iodine, external radiation therapy, chemotherapy, they come after surgery, not in lieu of surgery. Radioactive iodine is recommended after surgery in some patients. Dr. Larson will talk about it. And similarly, radiation therapy and chemotherapy are employed on certain selected patients due to the aggressiveness of their disease. Now, nearly all patients I see have already surfed the internet. And they come, doctor, are you going to do minimally invasive operation on me? So what is minimally invasive surgery? That means, basically it means a small incision or no incision. Small incision is fine, we can do it. Some surgeons like to use endoscopes, telescopes, rarely necessary. Some may use a robot, rarely required, if ever. Some may use remote incisions. That's like if you want to go to Brooklyn, you go to New Jersey, then upstate New York, and then come down the George Washington Bridge, and then go to Brooklyn. So people go from the armpit, from behind the head to get here. I would call it silly if not stupid. But generally, minimally invasive surgery is applicable only for very small tumors, tiny tumors. You can't talk about minimally invasive surgery in a 5-centimeter thyroid cancer. So here is a minimally invasive surgery. No fuss, no fancy, no folderol. Simple, straightforward surgery. No telescopes, no robot, and nothing else. So here is the incision in a young person, and here is a post-operative appearance following surgery. So that's what one should be expecting if you have a tiny little cancer. The extent of the operation will depend on the extent of your tumor and the nature of your tumor. I told you we have to be aware that the nerves to the vocal cords are around and they are at risk of either injury or the need to deliberately sacrifice, and similarly the parathyroid glands, which may require temporary supplementation with calcium following surgery. So we call an operation lobectomy, where we remove one half of the thyroid gland, one lobe of the thyroid gland, if the cancer is confined within the thyroid lobe and the other side is perfectly normal. Simple lobectomy, removing that half is enough, and that is curative. When the cancer spreads outside the thyroid gland, or there are multiple nodules of cancer, and papillary carcinoma is known to have multifocality or multiple nodules. That doesn't make it bad. Don't remember. If you got 3 little cancer, it's not worse than having 1 cancer. That's the nature of the beast. Or even if you have a benign goiter with nodules on the other side, we would recommend that the whole thyroid gland be removed. You heard about lymph nodes before from your friendly neighboring surgeon. The lymph nodes generally are clustered in the center of the neck. Occasionally, you see them on the side of the neck, and we need to remove them if they are involved or enlarged by thyroid cancer. Simply removing them to identify microscopic cancer there is not warranted, is not beneficial. And generally, this is the area in the center of the neck that we are most concerned about, enlarged lymph nodes. So here is an actual patient with a, don't worry, I'm not going to show you gory pictures. So this is the incision we use, and this young woman had multiple enlarged lymph glands. This is the type of incision we normally use, and this is what we expect to find several years down the road. This young woman had not only thyroid gland removal, but removal of lymph glands from both sides of the neck, and that's why the incision goes from one side to the other side. So extensive operations may be necessary, but that doesn't mean they are disfiguring or causing functional debility. So in conclusion, how do we translate for you the impact of what we do based on risk groups? To refresh your memory, low risk group, young patients, small tumors contained within the thyroid gland, high risk group, older patients, big tumors. In the low risk group at 10 years, mortality is 0. 100% survived thyroid cancer. Nobody died of thyroid cancer. People may have died of other causes, but not from thyroid cancer if you fall into the low risk group category. Even in the intermediate risk group, 99% 10-year survival probability. It's only in the high risk group that we see some mortality, and that's where we need to spend more time. So in summary, this is a fastest rising cancer in the United States, easily diagnosed. Most are small and early staged. Treatment is simple and safe. Cure rates are excellent. Awareness and early diagnosis are key to long-term cure. I can't leave the podium without telling you where can you find more information. So if you go to the internet and look for American Thyroid Association, you can download several brochures about goiter, about thyroid nodules, about thyroid surgery, and so on and so forth. And there are numerous organizations which are dealing with thyroid cancer as a subject. Light of Life Foundation is listed right here at the heart of the group. And self-examination is easy and quick. Examine yourself at least twice a year. If you find a lump, see your doctor. Remember what Joan Shea says. Don't forget to check your neck. Thank you.